Topic number 9. Diagnostic methods for surgical patients, pre- and post-operative period, surgical operation, complications in post-operative period. Lecture Shevchenko Alexander, Baltic Federal University, Medical Institute, Kaliningrad, 2020. First of all, we start communication with patient from the examination. And examination of surgical patient can be narrowed down to 3 questions: who to cut, what to cut, and when to cut. However, this is an oversimplification of the situation, and the assessment and the management of the surgical patient can be divided into a number of clearly defined steps. Establishing a diagnosis through history-taking, examination and investigation, formulating a management plan. Optimizing the patient comorbid medical problems and ensuring that he is adequately resuscitated. Regardless of whether the surgical patient is assessed on the ward, as an outpatient or as an emergency, the history and examination forms the most important component in establishing a diagnosis and evaluating fitness for surgery. More than 80% of clinical diagnosis can be made on an accurate history and examination alone. History. Be systematic in your approach. A careful, systematic history is as essential in the management of a surgical patient as it is with a medical patient. For the following format is the standard approach most commonly used: demography, presenting compliant, history of presenting compliant, past medical history, drug history, systems review, social history. Demography. Name, age, occupation, time and date, scene and source of admission should be documented. Age is especially important as it will point toward different disease processes in patients with similar symptoms but different age group. Present and compliant. The present and compliant should be no more than a few words and describes the patient being compliant and its duration. Example criteria: epigastric pain for 2 days, right breast lump for 5 weeks, etc. History of presenting compliant. The history of presenting compliant should expand on the presenting compliant in terms of its nature of onset, its progression, and associated symptoms and features. Relevant parts of the system's review should be brought forward to this point when particular system may be involved. For example, inquire about the upper gastrointestinal tract, hepatobiliary, renal, and respiratory systems when considering right upper quadrant abdominal pain. So pain is a common complaint, and the history should include its nature and duration of onset, any precipitating factors, its site, severity and nature, whether dull or sharp, colicky or continuous. Ask whether it radiates or has moved, and if there are any exacerbating or relieving factors or associated symptoms. Vomiting. Note onset on duration, persistence and contents, bile, coffee ground, blood. Was it preceded by pain? If so, the cause is usually surgical. Diarrhea and constipation may be relevant and incomplete bowel obstruction. Ask if the patient has able to pass flatus, as this is a more significant finding. Past medical history. Inquire about past medical illnesses, as these can influence surgical and anesthetic decisions and may require optimization before surgery. Inquire specifically about asthma, diabetes, hypertension, angina, recent myocardial infarction or stroke and jaundice, epilepsy, asthma, diabetes, hypertension, and angina. All need to be controlled prior to surgery. General anesthesia within 3 months of a myocardial infarction has an increased reinfarction rate of approximately 30% reducing over 3 to 6 months to a baseline that is marginally higher than normal thereafter. Thus, wherever possible, surgery following recent myocardial infarction and similar stroke should be delayed for at least 3 months, unless it is necessary. Jaundiced patients are at risk of having clotting disorders and are potential infection risk. Prevention surgical history should list previous operation, their dates and any complications. Inquire about anesthetic problems. Drug history. Regular medications, particularly cardiac drugs, should be continued. Even on the day of surgery, aspirin has a theoretical risk of increased postoperative bleeding, and some would advocate that it should be stopped 5 days before surgery. Oral anticoagulants should be stopped 3–4 days before surgery, and the patient heparinized during this perioperative period. Ask about steroids. The dose may need to be increased in response to illnesses or may need to be administered intravenously. Allergies to any medication or skin preparation should be noted. Systems review should assess the severity of comorbid medical problems and give an indication of functional reserve. Ask about weight loss. In females of reproductive age, inquire about last menstrual period, usual menstrual cycle, and the possibility of pregnancy. Social history. This is frequently overlooked but is important in influencing decisions regarding suitability for day case surgery and the discharge of patient back to the community. Inquire about smoking, alcohol intake, and occupation. Examination. This should include a general examination of the patient, including the cardiorespiratory system and abdomen, and detailed examination of the affected region of the body, example groin, lung, abdomen. It should be systematic and follow the pattern: inspect, palpate, percuss, and auscultate. General examination. Weigh the patient, assess the state of hydration, skin turgor, furry tongue. Look for jaundice, anemia, cyanosis, clubbing, peripheral edema, lymphadenopathy. Record the core temperature. If pyrexial, are there rigors? Cardiovascular examination. Check pulse, rate and rhythm, blood pressure, jugular venous pressure. Listen to murmurs. A tachycardia may be due to anxiety, shock, or pain. Beware of the beta-blocked patient. Beware of hypotension. It is a late indicator of shock. Uncontrolled hypertension, diastolic more than 100 mm hydrargyrum, runs an increased risk of myocardial infarction and a stroke and should be corrected before elective surgery. Heart murmurs or prosthetic valves require antibiotic prophylaxis before surgery. Respiratory system. Check respiratory rate, position of trachea, movement of the chest wall, air entry, percussions, breath sounds. Tachypnea occurs with pain, shock, and sepsis in condition to chest pathology. Examination of the abdomen. Develop a system for examining the abdomen. Inspect, palpate, percuss, auscultate, exposure the abdomen from nipples to knees during the course of your examination. Inspect. Look for swelling, distension. Think of the 5 F's: fat, feces, fetus, fluid, fetus. Are there any skin lesions? Example: gradual spider nevus, liver disease, pigmentation, Addison's disease, caput medusa, portal hypertension, which you can look here. Striations, pregnancy or Cushing syndrome or disease. Tortuous veins, inferior vena cava, obstruction. Look for scars. Do they correlate with the surgical history? Does the abdomen move freely or on respiration? Does the patient move freely or lie still with diminished movements on breathing? If the latter, this may suggest peritonitis. Are there any visible pulsations? The aorta can be seen to pulsate in thin patterns on or in aortic aneurysms. Right ventricular pulsation may be transmitted to the epigastrium, and tricuspid regurgitation may cause a pulsatile lever. Be clean about the difference between a pulsatile and expansile mass. Fingers move in the same direction when encompassing a pulsatile mass. If movement is transmitted by the mass, but in opposite direction for an expansile mass. Are peristaltic waves visible? If so, where and in which direction? A left or right in pelvic stenosis, a right to left in transverse colon obstruction, and ladder pattern in for small bowel. Palpate. Be sure your hands are warm and that the patient is lying flat within head on a pillow. Position yourself at the same height as the patient abdomen. Ask where the most painful area is and start away from it, walking around to this area last. Lightly feel for any tenderness, guarding, or masses in the 9 regions of the abdomen, and then repeat, palpating more deeply. Watch the expression on the patient's face. This can be more revealing than waiting for patient to tell you something hurts. Determine the size, shape, consistency, and mobility of any masses. Lever. Starting in the right iliac fossa, dipping the fingers to feel for an edge as the patient breathes in. Note the relation of the edge to the costal margin, its consistency and contour, and any tenderness or pulsation. Spleen starting in the right iliac fossa again, working up towards the left upper quadrant. It is characterized by 4 features. It moves on respiration, has a notched lower edge, no upper edge is palpable, and it is dull to percussion. Kidneys. By biminally palpating them, unless the patient is thin or the kidney is grossly enlarged, they are often impalpable. Not any tenderness when diluted from the back. The uterus and bladder emerged from the hypogastrium, and their size is assessed by height in relation to the umbilicus distance from the symphysis pubis. A situs, if marked, can produce a fluid frill on one flank when an assistant places a hand in the midline and the other flank is tapped with a finger. Aorta. Nothing is caliber and femoral pulses, nothing the relation to the radial pulses. Noting their relation to the radial pulses. Percussion. Confirm organomegaly of solid viscera by percussion. If a site is suspected, check for the shifting downers by percussing from the midline laterally until downers is obtained. Then roll the patient away from the site. Subsequent resonance on percussion is consistent when the free fluid in the peritoneum. Auscultate. Listen for bowel sounds. They are diminished or absent in peritonitis and ileus and increased in obstruction. A suction splash may be heard in pelvic stenosis. By rocking the abdomen, listen for bruits over the femoral and renal arteries. Groins. Look for hernia or glands. Reducible inguinal hernias may disappear with the patient flat and appear on cathing, straightening, elevating the legs. They always lie above and medial to a line drawn between the pubic tubercle and anterior superior iliac spine. Feel for femoral hernias inferolateral to this line. They always occur medial to the femoral pulsations. Beware of any irreducible tender lumps in this region. They may represent an incarcerated hernia. Genitalia. Do not overlook this part of the examination. In males, examine the testes for any unusual surveillance or tenderness. Look for cellulitis of the scrotal skin. Feel the cord. Any lumps appearing above them are inguinal in a region beneath a scrotal. Look for any penile abnormal itches or urethral discharge. transilluminate any swellings to see if they are solid or cystic. In females, examine for any vaginal discharge, warts, and when necessary, perform a vaginal examination. Rectal examination. Note any hemorrhoids, external skin tags, fissures, or perineal warts. Perform a genital digital examination with a lubricated index finger, assessing for any intraluminal or pelvic tenderness or masses. Noting their relation to the perineal body, assess the anal tone. In the male, assess the prostate gland in terms of size, symmetry. There should be a central sulcus in the normal prostate, and consistency. In females, feel for cervical excitation suggestive of pelvic inflammatory disease. Note for presence of any blood, mucus, or pus on the withdrawal of the finger. If necessary, proceed to a proctoscopy and rigid sigmoscopy. This is 9 parts divided parts of the abdomen, and here we have in the right upper quadrant and right hypohastrum the most common causes of the pain is hepatitis or cholecystitis. In the upper part of the abdomen or epigastrum, we have peptic ulcer, pancreatitis or leaking aneurysm of the abdomen. In the left subchondral or left part of the epigastrum, it can be infarct of the spleen or splenic rupture. In the right lumbar region, it can be ureteric or renal colic and leaking aneurysm too. In the mesohastrum, all the parts of the mesohastrum, reasons of the pain can be leaking aneurysm. In the umbilical region, it can be small bowel obstruction or uncarcerated hernia. In the left lumbar region, ureteric or renal colic. In the right hypogastrum, we have appendicitis, Crohn's disease, Meckel's diverticulum, it most common reasons. In the pubic region, it can be large bowel obstruction, urinary retention, ovarian cyst, ectopic pregnancy, salpingo-arthritis, appendicitis too. And in the left hypogastrum, we can have diverticulous disease. How to describe specific region? First of all, examine the affected region of the body, examine the lump. Any lump can be described using the following features: size, shape, and contour: smooth, well-defined or edged, consistent, fluctuant, hard, rubbery, consistent, color of the overlying skin, temperature, tenderness, transillumination, like hydrocele in this picture, fixity, is it fixed to skin or underlying muscles, pulsatility, pulsate it or transmitted it pulsation, maybe it will be aneurysma, and reducibility if you examine the hernia. Investigations. Avoid unnecessary investigation, they are costly and can carry a significant morbidity and mortality. Choose the cheapest, easiest, safest and most convenient one, most likely to give you the answer you want. Investigation can be specific or general. Specific investigations are used to establish a diagnosis or determine alternative plans of action. General investigations are used to assess perioperative fitness for surgery. If in doubt about which test to choose, seek the advice of your colleagues or the lab. If patients have comorbidities, call a specific physician for consult. For example, if your patient have history of heart disease, like a heart attack few months ago, called a cardiologist. And if your patient have chronic, I don't know, maybe chronic bronchitis, you can call therapist or pulmonologist. The perioperative period is the time of a patient surgical procedure. It commonly includes ward admission, anesthesia, surgery, and recovery. Perioperative period may refer to the three phases of surgery: preoperative, intraoperative, and postoperative. Though it is a term most often used for the first and third of these only, a term which is often specifically utilized to imply around the time of the surgery, the primary concern of perioperative care is to provide better conditions for patients before operation, sometimes contracted during operation and after operation. So, preoperative period. The preoperative phase is used to perform tests, attempts to limit preoperative anxiety, and may include the preoperative fasting. Intraoperative. The intraoperative period begins when the patient is transferred to the operating room table and ends with the transfer of a patient to the post-anesthesia care unit, or in Russian palata пробуждения. During this period, the patient is monitored, anesthetized, prepped and drained, and the operation is performed. Nursing activities during this period focus on safety, infection prevention, opening additional sterile supplies to the field if needed, and documenting applicable segments of the intraoperative reports in the patient's electronic health records. Intraoperative radiation therapy and intraoperative blood salvage may also be performed during this time. Postoperative. The postoperative period begins after transfer to post-anesthesia care unit and terminates with the resolution of the surgical sequel. It is quite common for the very last of this period to end outside of the care of the surgical team. It is uncommon to provide extended care past the discharge of the patient from the post-anesthesia care unit. Indications for surgical treatment. Indications for surgical can be absolute and relative. Absolute indications are conditions directly threatening the life of a woman or man, accompanied by a picture of an acute abdomen, bleeding during ectopic pregnancy, rupture and perforation of uterus, twisting leg of ovarian cystadenoma, rupture in the ulcer, it can be perforation of any organ, peritonitis, appendicitis, gangrenous cholecystitis, and etc. An examiner of relative indication for surgical intervention can serve as the omission of the walls of the vagina and uterus, malformation of the genital organs, not incarcerated hernias, chronic cholecystitis, etc. Contraindications to surgical treatment. When deciding on the question of surgical treatment, contraindications to surgery must be considered. These include, in particular, severe diseases of the cardiovascular system, diseases of the respiratory system, liver, kidneys, and other organs and systems that severely disrupt the general condition of the body and its compensatory and adaptive mechanism. However, in a number of cases of providing emergency care for life indication, it is necessary to perform the operation, despite the existing contraindications. Here we have assessment of the physical status by the American Society of Anesthesiologists, or shortly ASA. First grade, it's normal, healthy patient. Second grade, patient with mild systemic disease. Third patient with severe systemic disease. Fourth, patient with severe systemic disease that is constant threat to life. 5. Moribund patient who is not expected to survive without operation. And 6. Declared brain dead patient whose organs are being removed for donor purposes. And additionally to this, we must add letter E which mean emergency if our operation is urgent. If you want to assess the risk for your patient, we have so many different calculators, and I'm use British calculator to assess the risk of postoperative death, thromboembolic complications, urinary tract complications, and we have parameters here to fill, and after we fill it we can press the button continue and have the results. Here we have predicted length of hospital stay, serious complications, any complications, postoperative pneumonia, cardiac complications, surgical site infection, urinary tract infection, venous thromboembolism, renal failure, risk of readmission after a specific type of the operation, return to operating room, death, discharge to nursing or rehab facility, and sepsis risk. Preparation for urgent operation. First of all, every patient that in the health mind might sign the consent. So take consent for all procedures. If this procedure is invasive, always take consent, because this is very smooth judge moment. So if you didn't take consent and provide some operation, this patient can sue you and you will be pay a lot of money. So if you take consent, clean the operating field, shave the operating field, place the gastric tube to provide aspiration of the stomach contents if the patient eat more than 6 hours, less than 6 hours before operations, and if it drink water less than 2 hours before operation, and if it's indicated, give the antibiotic for prophylaxis. Before planned operation, take consent for all procedures. Patient must be washed in the bath or shower, shave the operating field. Patient must be feasted before operation. Fasted before operation. If we have indication, use preoperative antibiotic prophylaxis. Fasting. 8 hours before surgery, no meat or fried fatty food. 6 hours before surgery, no milk or solid food. If we have breastfed infants, no breast milk 4 hours before surgery, and 2 hours before surgery, nothing you can eat or drink. If we talk about adults, it's 8-6-2 rule. Consent. Successful surgery depends on a relationship of trust between the patient and doctor. To establish thus, this patient rights to autonomy must be respected, even if their decision results in harm or death. This right is protected by law. Thus, patients should be given sufficient information in a way that they understand to enable them to make informed decisions about their destiny. Good consent in practice. The key to good consent is effective communication. Choose a quiet place, free from disturbance, avoid standing over the patient, and use plain English, avoiding jargon. Take time, or maybe not English, any language, avoiding jargon. So if you talk about esophagus surgery, you must say to the patient that this is a tube which connects your mouth and your stomach, because not every patient knows what does it mean esophagus. Okay, you must use plain and understandable by the patient terms. So At the end, check whether the patient has understood the information or wants more information. Remind them that they can still change their mind at any time or seek a second opinion if they so wish. Anesthesia in general surgery. For anesthesia in general surgery, both local, including epidural, spinal, and general anesthesia are used. There are a large number of narcotic analgesic drugs, muscle relaxants, neurotrophic drugs, ganglion blockers, and antihistamines, which allow to carry out a modern anesthetic aid for a variety of operations and carry out management of vital body functions during surgical intervention. Surgical operation. Surgery is a medical specialty that uses operative manual and instrumental techniques on a person to investigate or treat a pathological condition such as a disease or injury to help improve bodily function or appearance or to repair unwanted ruptured areas. Based on timing, elective surgery is done to correct a non-life-threatening condition and is carried out at the person's request, subject to the surgeon's and the surgical facility availability. A semi-elective surgery is one that must be done to avoid permanent disability or death, but can be postponed for a short time. Emergency surgery is surgery which must be done promptly to save life, limb, or functional capacity. Radical operations. Radical operations are operations that completely eliminate the cause of the disease. For example, appendectomy or cholecystectomy. In surgical oncology, radical surgery is surgery intended to remove both a tumor and any metastasis thereof for diagnostic and/or treatment purposes. It typically describes the removal of a tumor or mass and ancillary lymph nodes that may drain the mass. As in radical mastectomy, it is opposed to, for example, palliative surgery, which is intended for symptom relief rather than complete removal of cancer tissue. Palliative surgery. Palliative surgery is surgical intervention targeted to make a patient's symptoms less severe, thus make the patient quality of life better despite negligible impact on the patient's survival. Palliative surgery focuses on supplying the greatest benefit to the patient using the least invasive intervention. Palliative surgery provides symptoms relief and presentation of the quality of life in terminal disease status. The uses of palliative surgery can range from extensive debulking operation to less complex operation. Based on purposes. We have exploratory surgery is performed to aid or confirm of diagnosis. Therapeutic surgery treats a previously diagnosed condition, and cosmetic surgery is done to subjectively improve the appearance of an otherwise normal structure. Position of the patient on the operative table. Surgical position is the practice of placing a patient in a particular physical position during surgery. The goal in selecting and adjusting a particular surgical position is to maintain the patient's safety while allowing access to the surgical site. Often a patient must be placed in an unnatural position to gain access to the surgical site. Positioning normally occurs after the administration of anesthesia. In addition to consideration related to the location of the surgical site, the selection of a surgical position is made after considering relevant physical and physiological factors such as body alignment, circulatory respiratory constructions, and constraints, and the musculatory system to prevent stress on the patient. Physical traits of the patient must also be considered, including size, age, weight, physical condition, and allergies. The type of anesthesia used also affects the decision. Here we have supine, most often used position in abdominal surgery, prone position, Trendelenburg position. Trendelenburg position allows us to operate on the lower part of the abdomen because the bowels go up. Lithotomy position, this is most often used for the gynecology operation, and some, as from the name understandable, for some urologic procedures. Fowler and semi-Fowler position, this is not exactly the position on the operation table, but sometimes when patients have breathing problems, even through the tube, you must up you must give angle of the operating table upward, because it will be easier to patient to breathe. Lateral decubitus position, often used to the retroperitoneal space approach. We have 3 stages in every surgical operation: operative approach, operative maneuver, and closing of the wound. When we talk about operative approach must give us visual permission to the organ on which we operate. Operative maneuver, it exact deeds with the organ or site, and closing of the wound, we repairing all tissues which we damaged during the surgery. Minimally invasive surgery. Its procedures, also known as minimally invasive surgeries, encompass surgical techniques that limit the size of incision needed and so lessen wound healing time, associated pain, and risk of infection. Surgery by definition is invasive, and many operations requiring incisions or some size are referred to as open surgery, in which incision made can sometimes leave large wounds that are painful and take a long time to heal. Minimally invasive procedures have been enabled by the advance of various medical technologies: endoscopic surgery, rigid and flexible endoscopy. Rigid means laparoscopy and thoracoscopy procedures, and flexible means esophagogastroduodenoscopy by the flexible endoscopes, and colonoscopy by the flexible endoscopy. And we have duodenoscopes, it's also flexible endoscopy, which can provide lithotomy, endoscopic retrohead-cholangiopancreatography, and papillotomy in the biliary ducts. Postoperative management. First of all, we must monitor blood pressure, pulse, oxygen saturation, temperature, urine output, and surgical drain output. If a patient has a urine output less than 5 ml per kilogram in hour for last 6 hours, more than last 6 hours, check catheter patency. If we talk about 0.5 milliliters per kilograms per hour, we talk about adult patients, only adult patients. Okay. Supportive care in intubating patients, pain management according to World Health Organization analgesic later, stress ulcer prophylaxis with proton pump inhibitors, thromboprophylaxis with low dose low molecular heparin or unfractured heparin before and after surgery, especially for immobile bedridden patients. Incentive spirometry and breathing exercise in order to prevent lung atelectasis. Fluids replacement of ongoing fluid loss and maintenance fluid therapy. Enteral nutrition should be started as soon as possible to prevent villous atrophy. Daily examination of the surgical wound. Early mobilization. And postoperative pain control. The goal for postoperative pain management is to reduce or eliminate pain and discomfort with a minimum of side effects. Various agents, opioids or non-opioids, routes, oral, intravenous, neuraxial, and modes, patient-controlled, with as needed, for the treatment of postoperative pain exists. Wound complications: postoperative hemorrhage, wound hematomas or seromas, surgical site infections, and wound dehiscence. Incisional hernia, its late complication. General postoperative problems: postoperative fever, postoperative delirium, postoperative nausea and vomiting, postoperative ileus, deep vein thrombosis, pressure ulcers, and postoperative cardiac complications, myocardial infarction, arrhythmias, especially atrial fibrillation. Postoperative pulmonary complications: postoperative atelectasis, pneumonia, pulmonary embolism, renal and urinary tract complications, acute kidney injury, postoperative urinary retention, catheter-associated injury tract infection. Removal of the sutures: different parts of the body heal at different speed. Common time to remove sutures will vary. Facial wounds 3 to 5 days, scalp wounds 7 to 10 days, limbs 10 to 14 days, joints 14 days, trunk of the body 7 to 10 days. Removal of sutures is traditionally achieved by using forceps to hold the suture thread steady and point the scalpel blades or scissors to cut. For practical reasons, the two instruments, forceps and scissors, are available in a sterile kit. In certain countries, these kits are available in the sterile disposable trays because of the high cost of cleaning and re-sterilization. Thank you for your attention, dear students.